As many of you know, around the world, people have suffered a great deal during the COVID-19 pandemic, but I think we would all agree that the ability to connect in virtual ways like we're doing today is just a wonderful blessing, and I think the world has really seen the potential value of distance technology and digital technology to educate providers, to provide consults on individual patients, and to improve patient care. So we're at a really important time in medicine, in the kind of the evolution of medical practice. For a long time, some of the technologies and some of the interventions I'll be talking about have been available, have been technically feasible. But for many years, regulatory requirements and worries about litigation and physicians' responsibility for distance visits, payment structures, have really not allowed their great dissemination. And in the COVID-19 epidemic, what I'm seeing is that many of those concerns are quickly disappearing as health systems realize they need to take advantage of these new ways to connect. So what we need to do that is innovators, people that see the power of these technologies. Abbott has clearly done that in the field of medical education by putting together this master series. And I sincerely hope there are people that are listening today that will take some of the ideas that I'll be presenting and think of how they can be applied, in particular in your country and in individual health systems, to help some of the most vulnerable patients that we treat. So, it's a very exciting time, and it's a great pleasure to be with you. The one struggle that I've had in putting together this talk is the following. We are at a point where there is such an enormous volume of evidence showing the effectiveness of distance technologies in caring for patients that it's really, frankly, been a struggle for me to figure out how can I present this topic in a cohesive, coherent way that highlights some of the best evidence without having a lecture that goes on for hours and hours. I actually teach a course in this topic, so we have more than an entire semester of information and concepts and evidence. So what I've tried to do today is to select only some of the most seminal, most illustrative, most important studies that are some of the most rigorous study designs. So today we're going to be focusing mainly on randomized controlled trials and meta-analyses of randomized controlled trials. Okay, so mainly we're focusing on the most rigorous studies that in many cases, to me, have shown that these technologies need to be adopted around the world. They need to be incorporated into patient care. They're not necessarily active research questions anymore. We know things work, and it's really, I think, all of our shared responsibility to figure out how they can be used. My last brief introductory comment before getting into the main focus of my presentation today is that I do think, in all sincerity, that what Abbott has done in putting together this series of master classes is really quite brilliant and quite important. And what I mean by that is that, in the development and in the adoption of mobile technologies, there's often a natural instinct to go right to the novelty, right to the technology itself, without thinking about the content of the messaging or the behavioral science behind that messaging. Those interventions, those projects that are focused only on technology typically fail because we're frankly not very good at coming up de novo with messages that make sense and that are actually helpful to our patients. In my mind, it's sort of an analogy to think about, we're going to decide that we want to use more pills, more capsules in treating patients. Instead of thinking what is actually contained in that capsule, how it should be delivered, what are the contraindications to taking that medication, etc. Mobile technology or digitalization is the capsule. It's the delivery mechanism. And what's really important is to think about the behavioral science that all of you have heard about in the prior master classes. So that's why I really appreciate the way that Abbott has put together these series by emphasizing behavioral psychology and behavioral theory. And then that gives a nice foundation to really make sense of some of the digital ways of delivering those services that we'll hear about today. Okay, so let's get into it. Here's a brief disclaimer. Excuse me. And this is roughly what I'd like to do in the remaining time, the remaining 40 to 50 minutes that I'll be talking to you more formally this morning before we talk about questions. I want to start by briefly defining kind of the limits of the subject matter that we'll be addressing in this talk. As I mentioned, given limitations of time, we've had to put limits, and I've decided to focus really on digital technologies in what we call mobile health. And that typically means asynchronous, right, not real time communication with patients between face-to-face encounters. That's what mobile health is. There are, of course, other areas of digitalization that have been extremely important, like decision support systems that are integrated into electronic health record, like real-time consults, like video conferencing. There's enormous interest in that, and I think the research will bear out that those can be as effective, if not more effective, than face-to-face visits. There's a number of additional areas in the larger field of digital technology that we will not be focusing on. I'm going to be focusing on how we can use cell phones, essentially, to improve our contact and the quality of services that we deliver to patients between visits. And really, then, we're going to talk about why that topic matters, why it's worth all of our time this morning to be focusing on that topic. And we're going to focus on why it matters mainly by looking at the evidence. As practicing physicians, as scientists, evidence is what is the most important thing. As I mentioned, at this point, there's quite an enormous amount of evidence that a variety of these interventions can be effective for our patients. And near the end of my talk, I'm just going to very briefly introduce some of the more recent cutting-edge issues that we are involved with. We have a lot of projects involved in the area, in particular in artificial intelligence and automatically adaptive systems to really develop the next generation of these mobile technologies. So they're more patient-centered, they're more delivering information that's going to have a meaningful impact for patients, and that they actually result in the greatest outcome overall for the population. And so that's really our charge this morning in a general sense. As was mentioned, I direct the Center for Managing Chronic Disease, which is primarily located in the Public Health School here at the University of Michigan, although we have affiliates in engineering, in our informatics school, in nursing, in pharmacy, social work, around the university, and frankly, around the world. And what we do in our Center for Managing Chronic Disease is relevant to our talk today because it tells us how we can really conceptualize this topic of using mobile technology to improve patient care. We think about this topic along three separate dimensions. First, we think, what is the chronic illness that we're actually trying to address? And we have done projects, as I will mention later in my talk. We've done projects with patients with heart disease, hypertension, diabetes, and more recently, we have a great interest in mental health issues, including substance abuse, opioid addiction, depression management, and suicide prevention. So there's a variety of chronic illnesses, and I will mention a variety of chronic illnesses in my talk today. Then we also think about what is the population that we're trying to serve. How can mobile technologies help, for example, teenagers, teenage pregnant women? How can they help older adults? How can they help people that live in rural areas or far from their usual sort of care? And the way we think of technologies may be different depending on the population that we're focused on. As I mentioned, we have a large body of research internationally. There's been some great advances in international telecommunications just in the last 5 years that have made it much easier than ever to partner with large companies with names like Twilio or WhatsApp to do text messaging systems internationally or to reach patients around the world in some of the most distant or underserved areas. So the population matters, and cultural issues, language issues, of course, are going to be important. And then finally, we think about when we're saying mobile technology, when we're saying distance technology, what exactly are we referring to? And the field of mobile technology touches a wide range of what we consider different communication channels that have more or less evidence depending on how they've been implemented and what research has really been published today. So for example, what you would imagine. There's something that in this case might check someone's blood pressure, or if it's a diabetes patient using a continuous glucose monitor, they might have a special Bluetooth connection to a mobile phone to get tailored messages. I'm actually speaking with some endocrinologists later today about just that type of special device and connection. Special devices have been used with great success in the field of heart failure, specifically automated scales that patients can use at home that can alert them whether they're having a spike or a rapid increase in their weight that would indicate a potentially acute or dangerous event that requires medical attention and maybe hospitalization. So pedometers are another example that has been studied a lot. Those are special devices. Smartphones, many of the applications that we're talking about in this presentation may be used via smartphone, but here I'm mentioning specifically smartphone apps. And you can do a lot of things in specialized apps, and as we all know, there are literally thousands of apps out there for caring for diabetes, for caring for heart failure, for caring for chronic pain, post-traumatic stress disorder, etc. I'm mostly not going to be talking about special devices and smartphone apps today. First, for special devices, it's sort of, while they can be extremely useful in some special cases, it's not the most generalizable way of using mobile technology because, of course, you have to deliver that special device to the patient. It needs technical support. If the patient isn't using it, you might need a way to retrieve that device. It's kind of a more complicated and expensive use of technology that we really want to use only in special cases. In terms of smartphone apps, I'm making a generalization now, but smartphone apps simply don't have yet the broad evidence that other ways of communicating with patients has to date. This could change tomorrow. We could see an enormous, very definitive randomized trial of using a smartphone app for diabetes or cardiac care, something like that. But those haven't happened. And in many areas, what we've seen is that patients really resist the idea of downloading and using a specialized app. So that's a generalization. But smartphone apps are more complicated on the development side. There's some issues we could talk about at the end if people are interested. So I'm not saying that there shouldn't be a focus on smartphone apps, but it doesn't have comparably the level of evidence that other communication channels have, and I won't be emphasizing it quite as much today. The two other communication channels that I will be talking more about are very standard communication channels that can be used across a variety of phone types and really have been used in an enormous number of randomized trials, rigorous studies. First is automated calls, or IVR. IVR is an acronym, not particularly important, stands for interactive voice response calls. So these are the robocalls where patients can receive the call, hear recorded messages, and use their touch tone keypad to interact and receive targeted and tailored information. That is an area that we've done a lot of work on. I'll mention some of those studies later today. And IVR has some particular benefits. It's better for using multi-item survey questions that might be harder to deliver by text messaging. It's better for older adults, people that have literacy problems that don't text, right? So IVR has certain advantages. But then, of course, the very common communication channel that all of us are familiar with is text messaging. And that's really still the largest body of evidence that we have. More recently, in studies that we do around the world, we're integrating text messages in other communication platforms like WhatsApp. But it's the idea of sending text words and sentences, as well as now things like emojis, small sound or audio files, images, etc. That's all via text messaging systems. Texting is of course very common. It's something that everyone is already familiar with, and it's if someone has connection issues, that they have data issues, if they don't have access to Wi-Fi, texting requires low bandwidth, and so it has those advantages as well. So those are the range of communication technologies that we can think of overlaying or integrating with a project focused on a specific disease area, that's focused on a specific behavior, and focused on a specific population. So you can begin to see that it's really quite a complex set of dimensions or determinants in terms of thinking about and designing these mobile health projects. Turning now to look at briefly, why does it matter? Why is it worth our time today to be talking about this field of mobile health? Why should a health system that has not so far integrated digital technologies in their patient care, why should they invest the time and effort and resources in making that change, right? That's a very valid set of questions. And I think of the answer to that question in three ways. First, as you know, will not be a surprise to any of you, we now know that mobile phones are ubiquitous. They're incredibly common around the world and in a variety of populations. This is data from the International Telecommunications Union. That's an organization that's embedded within the United Nations. And they have actually, it's fun to go to their website. They have some really amazing data on communication technology and access to communication technology around the world going back for over 20 years. So what you can see from this particular graph is that with the top line, the light blue line, which represents more developed countries as they're defined by the United Nations, we now have almost as many or more phones in developed countries as we have people in those developed countries, more than 100 phones for every 100 people living in the country, right? The lower line is emerging economies or low and middle income countries. And even in those countries, there's been such an increase in telephone use, telephone access, that we have nearly to the point where 80, 90% of people around the world in low and middle income countries have access to a telephone. Now, I'm sure some of the people that are listening to me today can think of specific populations or neighborhoods or cities or small towns that are interesting to you and important, where people don't universally have access to phones. Those people are incredibly important. We can't leave them behind. But the fact is that around the world, phones have become increasingly common. So much so that the distribution, or when we think of the typical cell phone user, has really, really changed over the last 2 decades. So, for example, more data from the International Telecommunications Union, where at the beginning of the 21st century, most people that had a mobile phone or a cell phone, many of them, if not most, lived in an industrial country like the United States. But today, the typical cell phone user lives in a low or middle income country because most people in the world live in low and middle income countries. So this is an amazing thing. Just as I mentioned, us communicating this morning is basically a miraculous thing. These technologies, for the first time in the history of the world, have given us an opportunity to reach out and have frequent contact with people between face-to-face visits. It's really a revolution in technology that we hope will lead to a revolution in how we think about patient care. Just to drive this point home a little bit more, when there have been studies of some of the most vulnerable patient populations, and these are data from an amazing meta-analysis that was conducted here in the US, and it's a meta-analysis of individual studies that have tracked the proportion of people with schizophrenia, with psychosis, that have a cell phone. And it has data from studies going back to about 2007. Okay, so a number of different studies with hard evidence on cell phone penetration in this high-risk population. As I'm sure you know, people that have schizophrenia and that are living in the community may be homeless or have unstable residence. They often have extremely low incomes. They have unstable social networks, right? So we think of them as being very hard to reach. But as the lower line shows here, the proportion of people going up to 2015, the proportion of people in our country with schizophrenia who have a cell phone is now more than half. It's actually about 70%. Similar studies have looked at people who are homeless, have looked at teens who have run away from their home. They've looked at sex workers. We work a lot with people coming out of our prison system. And in all of those populations, the majority of people have a cell phone. So some of the people that we need to reach the most still have the capacity to communicate with us with their cell phone. So all we need to do is figure out how to make that communication successful. Okay, so that's the first reason why it's worth talking about it, about this topic this morning. But if that was the only thing, if that was the only justification for talking about integrating cell phones in healthcare, it really would not be a very compelling argument. We need more. The next reason why it's worth talking about the use of cell phones in medical care is because we have to recognize that there simply is not enough time during our face-to-face encounters to help patients make the behavior changes they need and to identify the patients that need additional support, additional monitoring to avoid an acute event. The good news from my field, which is really behavioral health, is that over the last 20 years, we've come up with a variety of specific behavioral strategies to improve patients' health and outcomes. We now know quite definitively how to help people with heart failure, for example, have a longer life expectancy. We know how to keep them out of the hospital. We know how to have them function better and to take their medications as prescribed. We also know quite definitively how to assist patients who need to stop smoking. We know how to help people lose weight. We know how to help depressed patients avoid suicide. All of that is amazing progress in behavioral health and great news. The bad news is that most of the interventions that we've developed in my field of behavioral health are delivered through one-to-one professional and patient in-person visits, and it's usually a series of in-person visits to make that behavioral change. So despite the really exciting papers that we've published in scientific journals, in most health systems, those sorts of services aren't available because the health professionals are simply not there. They're difficult to train. It's costly to provide that level of services. And to be honest, most patients that are struggling with serious behavioral health problems also have competing demands or other access barriers that are keeping them from coming in for all those frequent visits. So the traditional way of delivering these interventions during face-to-face encounters isn't working, hasn't worked, and as the population ages, that's going to become increasingly a problem. Of course, I don't even need to go into detail about how COVID has made that traditional model of in-person face-to-face visits simply unworkable around the world. Okay, so that's the second reason why this is a really important topic. And now let's talk about the evidence, right? So it's an important topic. People have a phone, but do these interventions work? And all of us, I'm quite sure, that are participating today are committed to evidence-based medicine. We don't just want another great new idea. We want to incorporate things that have a strong evidence base. Okay, so now I'd like to review some of the most exciting areas of evidence in the use of digital technology. When we think of things being effective in this sense in mobile technology, I do think it's useful to think quite specifically what we mean by effective. Effective in doing what? One of the ways mobile technologies have failed, have been less effective, is that people who are doing the development or trying to adopt the service are not thinking in that very concrete way what they're trying to do, what they're trying to achieve. But there's a variety of treatment goals, of clinical goals, that I think you'll agree can be served through the use of these mobile health tools. The first one of these is monitoring. So this is the concept of using mobile technology, cell phones, via text messaging, whether it's special devices, an app, whatever, to pull information from patients between face-to-face encounter so that clinical teams can evaluate that information, make clinical decisions about how to allocate their time to help their population avoid acute events. That's basically monitoring. In general, I can tell you that it's quite clear that patients are willing and able to report high frequency, daily, weekly, report information using their cell phone with a variety of communication channels about a variety of things. Right? There's a number of studies, for example, with substance abuse, alcohol intake, socially stigmatized sexual behaviors. People will report about that. They'll report about their symptoms of depression. They'll report about a whole range of things effectively using cell phones. And let me illustrate that with one really nice study that I did with my colleagues here at Michigan. There's an international study of childhood nephrotic syndrome. And we here at Michigan are a coordinating center. And my group had the honor of developing a text messaging system for this study. Right now we're working in 4 countries, Poland, Spain, Canada, and the US. I'm sorry, it's not Spain, it's Italy. So those 4 countries, Poland, Italy, Canada, the United States. And in that study, families of children who have childhood nephrotic syndrome are testing the child's urine every day for proteinuria, and they get a numerical result from the home test, and they're being sent a text every day and asked to report what those protein test results are. So in this particular published study, my colleagues did a really nice thing. There was a number of instances, about 150 times, when families or children reported by text messaging their protein test results, and then they went to clinic that same day and got a repeat of that test in the clinic. So that, of course, allowed a comparison of whether the home test was coherent or consistent with what clinicians were achieving in the clinic. And this is what they found. Right? So you can see here, 2x2 table. Down the left side was the home test report, and across the top, the columns, the same test results in the clinic. And when they analyzed the data, what they found is that in the vast majority of cases, it was the exact same value. Right? So this is typically measured statistically using something called a kappa statistic, and exact agreement between the home value and the clinic value. The kappa statistic was about 78, in the high 70s. Now, it is certainly possible physiologically that the person's result could change between the time they checked it in the morning at home and when they went to the clinic. And when they took into account those comparisons where the results were off by only one category, because the kappa statistic was really excellent. It was like about an 88, right? So this was very clear data that demonstrating that patients in this instance could in fact report clinically important information that clinics could take seriously for making decision makings, and that patients could do that using a text messaging system. Okay, so in general, that monitoring function is one area that I believe that mobile health tools can be quite effective. Another topic area was a quite large one. There's been a lot of research in this over the last 10, 15 years, is using text messaging to improve medication use, medication prescribing, and medication adherence. And let me highlight one study that frankly had a really big impact on me personally. I was so impressed by the results of this study. It was a study that was conducted about 10 years ago in Kenya, in Africa, and it was of patients with HIV disease. At that time, even more than today, many of you will remember that it was vitally important that patients take their antiretroviral medications exactly as prescribed, okay, to have good viral suppression, and that was extremely difficult for patients. So in this very large study, patients with HIV were randomized to usual care or text messaging that was designed to increase their medication adherence levels. And this is what they found. First, they asked patients after 6 months whether they were taking their medication as prescribed. And as you see on the left, they had a significant increase in the number of patients that were in fact doing that reported medication adherence. That was exciting, but not nearly as exciting as the two bars on the right side of this graph, which show viral suppression. That's exciting for two reasons. First, viral suppression is the determinant of complications and life expectancy, et cetera, for people with HIV disease. But from a scientific perspective, that's even more exciting because patients do misreport things like medication adherence. So it's not quite as reliable, the information on the left side. Viral suppression is a lab value. Patients self-report doesn't play a role. So that's very clear objective evidence that this text messaging system not only improved their medication adherence, but had a very meaningful impact on their health and on their prognosis. Okay, so that to me, this study I saw as being very important. Another study that was conducted in a variety of countries called the SIM card study used mobile technologies in a different way. This was a study where they were trying to improve community-level management of hypertension. It was a study that was conducted in China, in Tibet, in India, and in each of those countries, community health workers were going door to door, community by community, checking blood pressures, and then they were using, in the intervention group, a mobile health tool to make decisions about prescribing low-cost thiazide diuretic medicines to treat hypertension. And so just the management of a study of this size is always quite impressive. But the results were also quite exciting. What you can see is that in the left side, when health workers had these technologies, a tablet helping them to make decisions based on blood pressures in other comorbidities, there was a substantial increase in the number of people that were prescribed appropriately antihypertensives. Whereas in the control group, there was some time trend, but nothing nearly on the level of this intervention. So again, in areas where community health workers who might have much more limited education, might not have the supervision that they ideally would have, using mobile technologies to give them a structured way to make decisions, I think is a very promising way to improve patient care. And this SIM card study, this randomized trial, showed that quite clearly. Finally, this is a meta-analysis. We are required, some of you who are familiar with meta-analyses know this isn't the typical way of illustrating the results of a meta-analysis, but you can kind of get the idea. We were required to present it this way. And so in a meta-analysis, of course, it's an analysis of multiple randomized trials. Here, I think there's 16 separate randomized trials where the intervention was text messaging to improve medication adherence. So multiple studies with multiple chronic diseases, multiple medication types. So each of those vertical lines represents a separate randomized trial. And then on the right side, that blue diamond is roughly speaking a weighted average of the results of all those randomized trials. So this study was, to me, the final word, the most definitive evidence that using text messaging can improve adherence. What the investigators showed was this, that if one were to assume, as many people do, that people using chronic medications take about 50%. That's often kind of a rough estimate of what patients take in the real world. What this meta-analysis of these 16 separate trials showed is that mobile communication, text messages, increased medication adherence about 17.8%, an absolute 17.8%. So if they were taking 50% before receiving the mobile messages, at the end, after receiving the messages, they were now taking 67.8% of their medications as prescribed. So that's a very meaningful improvement that one could think of as translating into improvements in health. And of course, the other attractive feature of using something like text messages is it's very, very scalable. It's very, very low cost in terms of the marginal cost of including additional person in the system. So to me, what I say around the world, what I say in my own health system, is that this particular topic of should we use text messages to improve medication adherence, it's not a research question anymore. It's not something that's maybe even ethical to research, at least in the United States. We know these work, and they should be much more broadly implemented and adopted in health systems. Okay, so like I said, this study really, was the final word to me personally in answering that question. Now, we all know that medications are very important in managing chronic disease, but really most of the variance, most of the difference in outcomes across patients is typically determined by their lifestyle, by their diet, their physical activity, smoking, alcohol intake, etc. So there have been a number of important studies in using mobile technologies to address those fundamental lifestyle factors that are determining prognosis, complication rates, etc. for our patients living with chronic illness. So lifestyle behaviors is, again, another focus that we can have. And in that area, the study that has had really the biggest impact on my thinking, the study that is one of the main studies that I think of as so exciting, is the text-to-stop study, the text-to-stop study was published about 9 years ago, nearly 10 years ago. It was a study that was conducted in the UK using text messaging briefly to help people stop smoking. And text-to-stop excites me for a number of reasons. It's an impressive study, and it's impressive in at least 3 ways, if you'll permit me. First, it was just by its sheer size. It's a study of more than 5,000 smokers, right, across multiple sites. The organization and the funding of a study of that scale is not something we typically see, but this was a very large study, which makes it very definitive just by its sample size. In addition to that, patients at the end had their smoking status, their use of tobacco, confirmed biochemically, often typically by a saliva sample. That's important because just as with medication adherence, we do know that people can often misreport, so to speak, whether they're smoking or not, And there's a lot of social desirability bias. So when smoking status is determined only by self-report, the results are not quite as definitive. But in this study, they knew definitively whether people were smoking at the end of the trial. And the third reason that this trial, I thought, was incredibly rigorous is that patients were randomized to getting the text-to-stop series of smoking-related texts to help them stop and to not go back to cigarettes during the 6 months after they initiated the trial. That was one of the main intervention group of interest. It might be that people just getting texts about anything has some impact on their smoking rates because they realize it makes them remember that they're part of a smoking trial, et cetera. So what they did in the text-to-stop trial is that the control group was what's called an intention control group. In other words, the control group also received text messages. They just didn't receive text messages about smoking. They received text messages about dietary behaviors, things that weren't necessarily related to the behavioral outcomes. So that's a very rigorous study, very definitive in all of those three ways. What they found in the text messaging, at the end of the study, excuse me, sorry, I'm not seeing, oh yeah, there you go. The main finding from text-to-stop is in that first line here that you can see, biochemically verified abstinence at 6 months. And basically the text-to-stop intervention doubled smoking cessation rates. Smoking cessation is hard. The absolute rates are still low, frankly, I feel, in both these groups. But that is amazing that they were able to definitively show that they doubled cessation rates. With a difference of this size, that translates into one additional smoker that successfully quit for every 20 people that received the intervention. And some of you know, smoking cessation, if you stop smoking around age 45 or 50, that might result in a 7-year increase in your life expectancy. So for something that is so scalable, so low cost, to have one additional smoker quit for every 20 in the trial, I think is extremely exciting. So that's the text-to-stop study. There was a very similar study I consider it similar, that was then published in JAMA. And this was a study that was conducted in Australia among people with identified cardiovascular disease. Okay, so that's a little different than text-to-stop. But the results were at least as exciting. Patients in the intervention group received texts not only about smoking, but about a variety of cardiovascular risk factors. And what they found, interesting to me, is that even though the absolute rates of smoking were different, they were, 42% of people in the control group at the end were smoking compared to 26% in the intervention group. The relative decrease was about the same as text-to-stop. What I mean is that roughly half of the people in the intervention group stopped smoking by receiving these texts. Okay, so that was great news. In addition to that, there was a decrease in LDL cholesterol. They saw an improvement in systolic blood pressure. They saw improvements in BMI, physical activity, a variety of important cardiovascular risk factors in this high-risk population, people with identified cardiovascular disease. Okay, so another study from another country with another population that's showing consistent findings that text messaging can improve cardiovascular health and health behaviors. Finally now, changing to a very different topic, a very different type of intervention. This is a meta-analysis of a number of randomized trials using specific apps for preventing suicide among people with depression that are at suicide high risk. Maybe it's people with very severe depressive symptoms, people with suicidal ideation, people who had made a suicide attempt. And there have been a number of trials using different apps that all have similar characteristics. They all use something called cognitive behavioral therapies, which is really the evidence-based therapy for suicide prevention, but they were conducted in different contexts. And these investigators did a nice summary looking at the impact of all of those interventions on suicidal ideation. And, as we've seen in other areas, the results were so definitive that these investigators ended concluding that the digital interventions were so effective that they should be promoted and disseminated widely. Okay, so that's another topic area, and I barely scratched the surface. I'm just giving you an idea of the range of important topics that have been addressed by mobile technologies and the consistency, I feel, of the findings. Doesn't mean that all the interventions have worked, of course, but to me, there's enough of an evidence base that would suggest that these things should be really more broadly disseminated. I'm agreeing with these authors here. Now, early on, I mentioned that my own work over much of the last 15, 20 years, using technology has used robocalls, automated calls, and we've used them in some interesting ways with a variety of populations. But typically, these programs that we call the Care Partner Program have a similar structure, regardless of the clinical population we're dealing with. And in Care Partner programs, enrollees typically receive automated calls that last 3 to 5 minutes, and they receive those calls once a week at times that are convenient to them. And during the call, they hear recorded messages, requests for information, and they use their touch-tone keypad to make responses. And based on that interaction, our hope always is that there are 3 things that happen, basically 3 ways that we're hoping to improve that person's self-management and their clinical outcomes. First, during the interaction, based on their touch-tone responses, they can then hear recorded messages that are targeted and tailored to their unique needs. So we're hoping that patient education might have an effect on their health. In addition to that, based on what they say, automatic alerts are sent back to the clinical team so that they can intervene, make a phone call, schedule a visit, advise someone to go to the emergency room, etc. But the program is called the Care Partner Program because a unique feature is that patients enroll typically with a family member. It's often like an adult child who might be living outside the home. Sometimes it's a spouse. And based on what the patient is reporting, that person also receives structured feedback, often by an email, reporting in layman's terms how the patient is doing and giving that person very specific, concrete advice for what they can do to support the person's self-management. So that's the general structure of these care partner interventions. And as I mentioned, we've done them in a variety of areas. One of our first care partner studies was among patients with heart failure. And in that study, we did something really quite interesting. We were interested in knowing specifically whether that piece of feedback to family mattered, right? Maybe the whole intervention effect, if there was one, was determined by the self-care education or by the feedback to clinicians. And feedback to family might be nice, but not really effective. In this comparative effectiveness trial of heart failure patients, we randomized patients to have all the patients in the trial got the weekly IVR calls. So they all were able to hear the targeted self-care education. And all the patients in the trial, in both randomization groups, had feedback about urgent events to the clinical team. But only in one of the 2 groups was there that feedback loop to the family caregiver. So obviously this allowed us to test the marginal effect, the unique effect of that caregiver feedback on patients' outcomes. A very nice side effect of this particular study design is that, as I mentioned, patients in both groups were reporting information about their symptoms and about their behaviors every week to the IVR system. And we could use those self-reports as another way of tracking changes between the two randomization groups in how people were doing. And that's just what we did in this trial. So here, for example, you see this is data, weekly data, from patients in the control group where there was no feedback to the family caregiver. And in that group, over the course of the 12 months of participation, when patients were asked every week whether they were taking their medications as prescribed, roughly 60, 70, sometimes a little more, 60, 70% of patients each week said they were taking their medications, with the rest of the patients reporting lower levels of medication adherence. As you can probably see, there's really not big change over the course of the year. When we compared that to the group where there was feedback to the family caregiver, that looked like this. So it's quite obvious that there early on was an increase in self-reported medication adherence in that intervention group, right? So that was itself very, very exciting. We had other things that we could compare the two groups on using these self-report data. One outcome that's very important for people with heart failure is interference in their functioning based on shortness of breath. So kind of typical for this population, in the control group without feedback to a family caregiver, 50, 60% of participants each week reported that they were having limitations in their functioning due to shortness of breath. But in the intervention group where care partners, where family members were involved in the communication loop, we saw this. We saw a significant decrease over the course of the year, statistically significant decrease in shortness of breath reported by those patients. So we do have other data that suggest that the types of things that care partners were involved in, that family caregivers were getting more involved in, like medication adherence, really explain this difference or this impact of the intervention in the group where care partners were given the information they need to be more supportive in patient care. We did another trial that we just published in the last 6 months. There's a couple of papers that you'd be able to find online that was a trial of the Care Partner program conducted among patients that were hospitalized with a variety of high-risk, common chronic diseases. These were things like pneumonia, diabetes, heart failure again, or chronic obstructive pulmonary disease. For each of those conditions, there's a great concern that patients leave the hospital and they very quickly are readmitted. So the goal of that intervention was to decrease readmissions after the time of discharge through the type of intervention that is weekly automated calls, focusing on some of the main determinants of readmission across different chronic diseases, but focusing on the unique needs of patients with each of those clinical conditions. And this is what we found. We were really quite pleased with the results. In terms of time to first rehospitalization, the light blue line on the top is the patients who received the care partner intervention, and there was a significant decrease in rehospitalization rates over the 90 days after leaving the hospital. And when we looked at the combined outcome of rehospitalization or emergency room visits, we saw something similar. It was actually even a slightly greater increase at 90 days. That really showed quite clearly that the number of acute events was reduced substantially across disease conditions after people left the hospital. Okay, so there's just more evidence that this particular type of mobile health intervention with this particular communication channel can be effective. And finally, as a final word about these care partner interventions, there is a lot of concern sometimes that among people that review our papers for publication, or sometimes among clinicians, that says, wow, you're giving all this extra feedback to family members, and that might increase their depression and their level of stress because they don't know what to do, and they're getting feedback about worrisome symptoms and problems for their loved ones. We were able to look at this. We published on this. That showed that it's exactly the opposite of what actually occurred. Family members or other people close to someone with chronic disease are already concerned. They're often already stressed and by a sense of responsibility. And when you give them structured information about how someone's actually doing, with some concrete suggestions for how they can be helpful, they don't feel more stressed. They actually feel better. Okay, so in general, the care partner intervention has been very successful that way. And the last area that I'd like to mention is another area where we have used quite successfully IVR, automated calls, as an alternative to face-to-face clinical encounters. And it's the area of chronic pain where we've done a number of studies with colleagues at Yale University here in the United States. For people who are familiar with the area of chronic pain, you know well that it's one of the most common reasons that people seek medical care. At least in the United States, it's one of the main determinants of our epidemic of opioid misuse, addiction, overuse, and death. It's one of the main reasons people miss work time. It's one of the main causes of depression. Chronic pain is a serious and highly common condition. As in some of the other areas I mentioned, the good news is we know how to treat chronic pain. The best way to treat chronic pain without medications is through cognitive behavioral therapy, where patients are taught specific changes that they can make in their behavior, ways to promote relaxation, ways to promote a kind of a steady, measured increase in physical activity, ways to improve their mood, ways to change how they're thinking about their health. There's some very specific concrete interventions that are evidence-based and seen as really the guideline recommended treatment for chronic pain. The problem, once again, is that many patients with chronic pain do not have access to these interventions because they're intensive, they can be seen as costly, and because patients simply cannot or will not come in for a series of 6, 8, or 12 in-person hour-long visits in a health system. It just simply doesn't work. So what we did in this intervention is we tried to develop an IVR, an automated robocall version of that series of cognitive behavioral interventions that we could deliver to patients that could make the treatment more accessible and hopefully almost as effective as a real life condition. We conducted a randomized effectiveness trial where patients were randomized to either the real cognitive behavioral therapy with a trained therapist, where they came in for those in-person sessions, just as is recommended by our guidelines, or they received the same psychoeducation through the same number of sessions, 10 sessions in both groups. We addressed the same self-management skills in terms of the information content. Patients in both groups were assigned goals, like to use a pedometer and to, in a measured way, increase their step counts. Right? So we tried to make the two randomization groups as equal as we could. The idea when we started this trial was that we hoped that this IVR-delivered cognitive behavioral therapy would be almost as good as real-life therapy in terms of patients' reported pain and their functioning, their ability to get around. That's not what we found. We did not find that the IVR intervention was almost as good. We found out that it was at least as good and maybe even, for some patients, a little bit better. Right? So that was an amazing finding. Now, let me emphasize that I'm not someone who believes technology is miraculous. I don't believe that IVR-delivered psychoeducation is as good as a trained therapist. I do believe that the real human contact, that the provider-patient relationship is therapeutic and important. I honestly believe those things. But then how can we say that the IVR intervention was at least as good, if not better? Well, here's the reason. as what we found in this particular study. Typically, patients in the face-to-face intervention simply stop coming in because of all the barriers to access that I mentioned. Maybe they already think they're starting to feel better, so they don't come in. Maybe they're not getting any better, so they decide not to come in. So the total dose, even though we expected them to have 10 weeks of sessions, in that face-to-face group in this trial, the patients had on average 5 or 6 in total sessions. In the IVR group, because it's delivered in patients' homes, they had more sessions on average. So even if the potency of each individual weekly contact is less, the total dose and the consistency of psychoeducation was greater in the IVR group. Right? So even though IVR might not be as good in generalizing that mobile health contact isn't a real-life therapy, we can assume that more patients can get more support through these technologies, and as a result, we're going to be able to improve their outcomes. Okay, so these are all some of the studies that, like I said, have a great impact by their findings on how I think of the various roles that digital technology can play in improving our patient care. Now, just to end, let me turn to what I mentioned, or some of what we think are the most cutting-edge issues, some of the most exciting new developments in mobile health. Because like I said, mobile health is a developing field. While we see that it's had some great successes, there are some great limitations in terms of how we're delivering these interventions today. And let me describe them this way. When we try to think about how to make mobile health interventions, we're really trying to think of how to improve them as a therapeutic tool. And when we think of that, we can think of what we're looking for from a really good clinician, a live clinician encounter. That's really our ideal that we're hopefully trying to move towards in mobile health communications. And I've thought of this topic, what is a good doctor like, at least in terms of 2 separate dimensions. First, a good doctor makes evaluation or monitoring or assessment that is relevant to the needs of each patient. So let me give you a somewhat silly example that's not like that. Say I am a person with diabetes. I'm expected to come in to have a follow-up visit every 3 months with my doctor. And say I've had the fortune of having the same primary care doctor for 20 years. So I come and I meet that doctor the first time when I'm age 30. And the doctor asks me, John, do you smoke? And I say, no, doctor, I don't. I don't smoke at all. I come in 3 months later and he says, John, do you smoke? And I said, no. Like I said last time, I do not smoke. This goes on progressively year after year. Every time I come in, he says, John, do you smoke? 20 years later, he asks me, John, do you smoke? And I say, doctor, I've been coming to you for 20 years. Each time I tell you I don't smoke, and you keep asking me that same question. What a waste of time. So there's 2 problems with my doctor asking me whether I smoke. First, we could be using that scarce time to talk about something much more productive. And 2, I simply feel like they're not paying attention to me. So it really has a negative impact on our doctor-patient relationship. And instead of asking me every time do I smoke, what we really think the doctor should be able to do is take that series of responses in the past and use it to predict what my response should be today. And in this case, in the case of smoking, with practically 100% certainty, if you used in a rigorous and a systematic way my prior responses, you could definitely predict my response today with certainty, and we don't need to ask that question. Okay, so that's one example on the monitoring side that would be better if we used newer ways of incorporating artificial intelligence in mobile health tools. We typically now are not doing that. Patients get the same text message every day or every week. Did you take your medications as prescribed? And the answer, yes, no. and we're not using that series of values, that series of responses in an intelligent way. So that's one area where artificial intelligence and adaptive systems can be helpful. The second way is that we hope that a good doctor isn't treating every patient like a cookie cutter, like they're all exactly the same. Now, when doctors come out of medical school, understandably, they're more likely to do that. They have rigid rules. They hopefully know the guidelines. They have their textbook knowledge. And any person that just got diagnosed with type 2 diabetes is going to receive the same treatment. All of us would agree that we'd rather have a doctor who's been out in the field, that has a lot of experience over 10, 20 years, that has experience with other people like me, and also that maybe over time has experience in getting to know me and has a portfolio of different treatment options, different ways to communicate with me, different medication regimens, etc. And that doctor can take advantage of that range of treatments to make the optimal outcome decision for each patient and the optimal health status for the overall patient panel. Okay, so that's another very important way that we want to use mobile technology better. Let me drive this point home through two brief videos. I can't at this moment see the videos, but I'm assuming you're going to see the one on the left here, which is the simple wind-up robot. It's a very brief video, just to make a simple point. This simple wind-up robot is acting like many of our mobile health interventions today. And this poor robot has two really important problems that are related to the two characteristics of a good doctor that I just mentioned. This robot's first problem is that it really doesn't have any eyes. So you could wind it up and put it on the table, and it will walk right to the edge of the table and keep going, because it has no idea where it is, right? It has no way of getting feedback from its environment, and that's a big problem. The second big problem of this wind-up robot is that its action choices, its options, are extremely constrained. They're extremely limited. Step right, left, step right, right. That's all this robot can do. So if it's on the edge of the table, it's still going to step forward. It's the only actions it has. Or if you put it in the corner of a room, you all know what will happen. It'll keep facing the corner. It can't turn around. It does the same thing. Most of our current mobile interventions rely on tree-structured algorithms, predetermined, that give it limited options of, if you say this, I say that. If you do this, I do that. And no matter how complex we try to make those algorithms, those hardwired systems that determine the behavior, they're never flexible enough, given the complexity of life of our patients. So now I hope you're seeing the video on the right. This is really the new level. This is the ideal. This robot isn't determined by prescribed, predetermined algorithms and tree structures. First of all, it has eyes, unlike the first wind-up robot. It has sensors, quite a large number of them, to detect what's happening in its environment and how it might want to adapt itself to those new realities. In addition to that, it has much more flexibility. It has flexibility to rebalance itself and to step in different ways and to step at different speeds, so it can react to those realities in its environment. So that robot is learning in real time how to deal with a complex world. And if, as you see in the video, there's a sudden shock to the system, it can even learn over time to respond to that as well. So the robot in this case represents our mobile health tools. Its complex environment is our patients. Our patients are individuals with very complex, multidimensional realities. And even if we could develop a mobile health intervention that works for them at one point in time, they experience a shock to the system. And our mobile health tool should respond. So for our patients, their diabetes intervention might be working fine, but a shock to the system might come
when their spouse passes away, dies. The shock to the system might come when there's a pandemic and everything around them changes, or they lose their ability to pay for a certain type of treatment, right? Our mobile health tools can learn to adapt to complex environments and shocks to the system, right? So those are really the goals. The type of, very briefly, the type of artificial intelligence that is driving that robot is something called reinforcement learning. And it's an area that we work in a lot in some of our mobile health interventions. And it's very exciting. There are other areas of AI that have gotten even greater progress in the medical field, particularly diagnostics. So that's the ability to predict what's going to happen based on limited information. In diagnostics and artificial intelligence is really, I think, going to be very common in medicine in the next 20 years. And it relates to that problem of, really taking advantage of limited information and predicting, how to make decisions in the future. So let me stop here. I honestly don't expect you to be able to read all of these studies. I put them here only to illustrate a general point. Each of these articles that you see on this slide are a systematic review of mobile health interventions. And during my talk today, we've actually covered some systematic reviews, particularly meta-analysis in a wide variety of areas. There is now so much evidence in the year 2020 for different types of mobile interventions that, to be quite honest with you, academics have started to do something that I don't like, that I actually hate. And so you see that in the lower left, where not only are they reviewing studies and publishing that, but they're reviewing the reviews of the studies, right? So, we're really to the point where I feel in many of these areas, we need to move beyond simple academic research studies to the point where we're figuring out how to do large-scale adoption in clinics. So it's an exciting time, and I do hope that this is the beginning of a dialogue between myself, between all of you, with the support of Abbott, to figure out how we can make these various interventions really useful to patients with chronic diseases in the real world.